Good morning again, and I think the formidable task is going to be to present after such two very impressive presentations. This is making my presentation more difficult. So I'm hoping to cover why I believe the parenting process in the 21st century is going to be a formidable task, touching on points related to parents and child, highlighting the need for a paradigm shift, and then few take-home messages. It is formidable because everything changed and is changing at an extremely rapid rate. Concepts, expectations, norms of development, and as such, making 20th century models that have been for long had beliefs and models obsolete. The conceptualization of children has changed. What we expect of children and what they expect from adults has changed. They are entitled to what they want and not grateful for what they get, is a comment we often hear, at least here in this part of the world. What parents expect from themselves and what they are expected to offer by the society and their children has and is changing dramatically. The major challenge, I believe, is that what they experienced as models for parenthood when they were growing up no longer applies. Consequently, what is expected from professionals has changed. Their role is facing new challenges dictated by changes in the expectations and needs of society, children, and parents, and the demands of technology. For the sake of this presentation, when we say parents, we will mean both mothers and fathers. Thanks to the pioneers of the 20th century, the role of mothers and their relations with children, attachment and beyond, has been comprehensively studied. But what about fathers? Again, according to the 20th century Bowlby, fathers are useful. They provide for moms, they support moms emotionally, so that moms are able to devote themselves to looking after their children. So, unlike motherhood that is defined in terms of mother's relation to the child, the father role is defined by his relation to the mother and as being the breadwinner. By the end of the 20th century, a lot of fathers felt they are second-class citizens in the life of their children, or at best, an additional attachment figure. Is this going to carry on in the 21st century? Apparently not. Things are changing. Why? Because fathers are no longer the sole breadwinner, but co-breadwinners. Because of the escalating divorce rates that I think is global now, fathers outside the constitution of marriage see their children, and as such they need to pick up skills on how to relate to their children, not only without the mother's help, but also without her presence. Those still within the constitution of marriage, I think, had better think about how to do things differently. So by the 21st century, the issue of equality is taking the upper hand. But fathers are asking for equality and not sameness. Fathers are not mothers, although the same principles of care apply. However, fathers do it in a very different way. And yes, it is working. Children do seem to benefit from different models of care. So we can say that there is a new pattern of fatherhood emerging, where fathers are directly involved in the care of their children without the mothers being in between, and they are involved, providing quality, not contact. Child. We are always working with children. Everybody is saying children have changed. They have changed. Have they? And more challenging, have their patterns of development changed? It seems that in the 21st century, an important change is the valency of the components of the parent-child dyad. Parents come to seek advice. We are not talking about diagnoses. We are not talking about illnesses. We are talking about relationships. So they come complaining that their children are stubborn, they are defined, and effectively in charge. So in a way, parents are coming asking for empowerment. Should we help? Can we help? We always say we are working with moving targets because children are always changing in what is called process of development. Not only that, but different domains of the child develop at different rates. Quite often we would get a father or mother saying, my kid is way ahead of his age. When you hear him talking and the way they think, I'm very impressed. And then the child will act emotionally his age. So parents logically ask, with whom should I interact? With the cognitively 7 or the emotionally 4? And here again, we need to help. I think as professionals as well, we're starting to ask ourselves often, are the norms of development that we have studied in the 20th century still applicable? Are children developing differently? I think yes, it is expected, especially that they are developing in the cyber age. When everybody has access to the same source of knowledge, acting that younger means quicker and more efficient, who needs to ask who? And what is happening to spoken language here? Do they need to talk to each other? And then in clinics we keep on talking about delayed language. Can we ask which language? I think it's the 20th century language, but with the 21st language. They don't talk yet. So which delay? With all these changes, a lot of the 20th century slogans are obsolete. I don't think that a parent saying, because I say so, is abiding or convincing anymore. And definitely it will not be palatable in the 21st century to attribute an illness to a refrigerator mother or a schizophrenic mother. Would you agree that in view of all these changes, the field needs a paradigm shift? There are several components that need to change. And actually, the model offered by the Touchpoint Center of the Brazelton seems very effective here. I think we need to change from a deficit model to a positive model. Our profession so far has been haunted by looking for deficiencies. Time for a shift. A move from focus on the child and family deficits to a focus on their positive attributes. A proactive focus on child and family competencies seems essential. The second dimension is that of development. The conception of development that implies a gradual accomplishment of universal milestones needs revision as well. Normal development does not progress evenly nor gradually along a smooth upward line of development. Actually, development proceeds in spurts and plateaus, denoting rapid growth and phases of gradual growth. It's not continuous. The rule is to be discontinuous. It is discontinuous with normal phases of disorganization. Typically, before a period of rapid growth, there is some turbulence. I will give an example from early childhood. So, if we have a baby of 10 months or 11 months, and the baby discovers he can pull up himself and stand, what happens? Everybody is rejoicing. Everybody is so happy. And he is very proud of himself, of course. is standing like everybody else, every adult around him. Once and again, and everybody is rejoicing and applauding. Then one night, middle of the night, the baby gets up, holds to the rails of the crib, and here we go. He's waiting for the applause. Very proud. What happens? Mom rushes there to put him back to sleep. Now this is a very different reaction, isn't it? No, I'm not sleeping. I want the reaction, I want the applause, I want the rejoice. Now Mom becomes very tense and anxious because she can't imagine we are back to the phase of sleepless nights. And what has happened? What have I done wrong? Why are we regressing in a skill that we have gained? So we end up with a fussy child, frustrated and maybe an angry mother, instead of having a smooth acquirement of a new skill. And this is risky. Why? Because if the parent system cannot accommodate this normal disorganization, the threat is a developmental derailment. Well, I think we should tell parents in advance if their kids are starting to walk, they should expect a sleep disturbance. The third dimension is change, a shift from being prescriptive to being collaborative. Professionals tend to be prescriptive with the subtle assumption that experts should know best. What we really know is there is no way to know it all. Each family has its uniqueness. The one-size-fits-all is non-applicable. With collaboration, we mean recognition that the parent's expertise is of great value, and rather than giving one-sided directions, to establish partnership with the parents is more productive. We have been trained that the gold standard is to be objective, but what about empathy? It is greatly needed, because just as parents will not benefit from a directive one-sided advice, they will not benefit from a dispassionate, aloof approach. So if the aim is an authentic alliance, then practitioners' emotions are resources, especially when used knowledgeably, and they would be very constructive. This is not new. I think this was what Hippocrates meant when he said, let your best means of treating people be your love for them, your interest in their affairs, your knowledge of their condition, and your recognized attentiveness to them. A very holistic approach. Not zooming on negative things, not zooming on even diagnosis. Well, if we agree that parents are experts, and that professionals or parents are two bodies of experts collaborating together, what will happen to the strict discipline boundaries we are abiding to when we were the sole experts? Is there room for flexibility in our profession? Can we consider an alternative way of practicing? I think this will be the challenge, and it needs a lot of creativity. Okay. Take-home messages. Theories should remain theories. They should never be converted to ideologies. No matter how long a theory will continue to hold its ground, it will change. And the 21st century, I think, is going to witness a lot of changes. We need to collaborate with parents, but we need to stop limiting ourselves to mothers if we have a choice. Sometimes fathers don't show up in this part of the world. This is not about feminism, this is not about a revolution. When we talk about parenting, it doesn't make sense that we dismiss 50% of its manpower. Throughout our continuous professional development, we strive to update knowledge and add new skills. I think at least in the area of parenting, we need more. We need a paradigm shift. Thank you.
Thank you, Suaad. This was amazing.
We just finished 3 amazing talks here in this room, and we are open for any questions for any. Yeah.
Could I, Harry's lecture, can I just raise something that we might want to look at? Reference has been made to the problems of diagnosis. And I hope everybody is aware that some diagnoses are concepts. Pneumococcal pneumonia tells us what the cause, etc. is. But many psychiatric diagnoses are operational definitions. They simply describe what you see, and we should be very careful and very aware. I'm asking this as a question, should we be very careful and aware to say that these are almost certainly heterogeneous, and we should look for the differences if we are going to get our response correct. I hope that makes sense.
Yes, thank you for this question, which is a very old question within the field of psychiatry, and I have thought a lot about it, and I am much more skeptical about the differences between psychiatric diagnoses and diagnoses outside psychiatry. I would just give you 2 examples. The first one, traditionally, a disease is a syndrome which can lead to a prognosis, a treatment, and with an etiology. And there is quite a consensus between countries about that. Sometimes there is an addition of the word lesion, but this is not the case in general. But do you know the etiology of acute leukemia? There is no etiology of acute leukemia at the moment. And anyway, people will never say that acute leukemia is not a disease. It is a disease. And on the other way, nowadays in psychiatry, we have, for most disease, some kind of etiologies, whether they are psychodynamic or neurobiology. And so I think that the differences between psychiatric disease and organic disease at the moment are mainly sociological, more than objective on a clinical point of view. Because psychiatric diseases are related to the mind, we are embarrassed to say that they are disease. But when you see exactly the criteria, and the other example is about infectious disease. Traditionally, we say tuberculosis is due to germs, and there is a cause, and in mental disorder we have not that, but in fact, in tuberculosis there is a genetic vulnerability, and there is also an environmental vulnerability. And the germs, in fact, is not a cause, but a necessary condition. And after all this year of thinking about mental disorders, I do think that there are mental diseases, just like in other medical disciplines. But this, I know this is an open discussion and very difficult.
Good morning. Thank you for this excellent presentation. I would like to ask Dr. Clark. In your trial about body dysmorphism disorder, you presented something that is, for me, very similar to how you treat OCD disorder. So, is there any specificity that you've introduced in this trial regarding specific techniques in CBT addressing body dysmorphism differently than when you address OCD? Thank you.
Yes, I mean the similarities are tremendous to OCD because it's one of the OCD-related disorders. So the central tenet of treatment is exposure with response prevention. Now there is a debate within the literature overall as to whether habituation as a key component of that treatment is what's required. There is something about the learning process that goes on during ERP-based CBT. So the similarities are enormous, but yes, I alluded briefly to some of the packages that are specific to BDD. So certain young people have, for instance, particular difficulties with reflective surfaces. The way they look at themselves in the mirror it's been studied and is very different to controlled populations. And so we would potentially include, for those kids who need it, training on how to look at and how to live with mirrors and reflective surfaces. There are also components that are added in as needed. As I say, on attention training, there are many of the kids who come through need work on previous traumatic experiences and have particular traumatic memories. So there are enormous similarities, and that's why it sits well in our team, where the majority of the patients we treat have OCD, but yes, there are differences in the overall. All the gentlemen over here.
It's okay. You have the mic. So I actually have two questions. First question for Dr. Moussa, and again, thank you for all the speakers. I really enjoyed the presentation. One is about parenting and the cultural aspect of parenting. One challenge I face as a practicing physician in the U.S. when I see people who are say from the Middle Eastern region, but other regions of the world, like Hispanic populations, is the use of physical discipline. And while in the U.S., if anyone just touches a child, we are supposed to report. I understand that's not the case in other cultures. So how do you see this issue evolving in kind of the Egyptian content, the use of physical discipline, and at what point is it discipline, at what point is it abuse? And then, so that's the first question. The other question for Dr. Falasard. You have very thought-provoking ideas about the future of our field and how it's evolving. One question I have for you is, how do you think we as psychiatrists should position ourselves in the broader mental health field? So you mentioned Boston a few times as one of the areas with the highest concentration of child psychiatrists in the world, but still there's a shortage even in Boston. And what we're seeing happening in the US is psychiatrists being very limited to medication management, but not even enough for that, where there are nurse practitioners now who are licensed and they work in medication management, and we're seeing also psychologists in the US and some states gaining prescribing rights. So where do you see us, should we stick to our medication part and try, to do a better job with it, or should we, shift somehow?
You mean 1 hour?
I think it's a very important question, the one you are asking, especially when we are teaching. So when is it discipline and when is it abuse? Yes, because I think it would be different from one culture to another, even within the Egyptian society, we may say that. We know that this is a way of discipline in our culture. So what measure are we going to advise so that it is not overused, number one, and that it is effective? Because in the clinical practice, the first thing is no harm to the child, yes. If children grow up in a society where this spanking and so on is happening, I think it would be very interesting to do research and see how children see them. I would like to know from the children themselves, rather than impose as a professional.
But I mean, abuse is abuse. I know that you can move the line. This harm will depend on harm. This is only definition, so this is something that you will take into consideration. Quite often, I find younger colleagues asking parents not to use physical discipline. And one would see, well, how can I discipline? So either you offer effective methods. I think the point is to offer parents effective methods that would convince them not to use them.
I will not thank you, Ishan, for your question. No, I think, well, to be short, of course it depends on the country where you live. I will just give you an example. In Germany at the moment, it is more difficult to become a psychologist than a psychiatrist. And the way that psychologists are educated is amazing. And of course, in many other countries, in mine, for instance, this is completely different. So that shifting cannot be the same according to country. But anyway, I have some direction in mind. First, obviously, only psychiatrists have the global picture of somatic comorbidities, which are often an important part of our job. And of course, psychologists are not trained for that, and other disciplines are not trained for that. So the picture about the kid is not only a mind, but a brain and a body with organs. This is something which is real psychiatry. The other thing is that psychiatrists have an authority that is given by the society. Adult psychiatrists can lock people in hospital. And we have also this authority on patient. And this makes the difference between psychiatrists and psychologists. And so we have more authority to say to parents, no, you do not consider the problem enough. You are making a wrong decision. I think psychiatrists are more comfortable having authority with parents than psychologists. And the third point is that I think that in the future we will have to deal more with very severe disorders, and the other member of the team will be better with the less severe disorder. But who knows?
And maybe adding to the more senior you are as a child psychiatrist, you have more authority with the fathers. You can tell them off as well. Bruce, just a question really regarding the individuals who had dysmorphic beliefs regarding their nose. Is it related to the nose being a phallic symbol? Is it also related to, because the nose, I had a patient where the nose does change shape at adolescence. And is it also related to gender issues at that time, which is quite crucial in adolescence as well?
I'll start at the end, because that's the bit that's a little easier to answer, in the sense that people have looked at particular features, body image features, and looked across genders, and they seem to be fairly well matched, but not in all populations. So, for instance, I mentioned the group in Iran. There's a very good group in Iran where within that culture that eyes and nose, because of its prominence with the way that females present themselves within that culture, it's much more salient and much more common for the image concerns to be focused on the central part of the face. That's the only piece of the face that's very often seen within that culture. So culture has an important impact. But within the UK and North American culture, the concern regarding nose, for instance, is fairly evenly distributed. Now on to the more difficult part of your question regarding phallic symbol. I just don't know. It's not something that's been well written about. There's a long history of psychoanalytical theories applying to the broader group of OCDs, but very much more typically focused on OCD. There's not a lot of psychoanalytical writings around BDD as such. However, our twinned service, we're twinned with the clinic at the Karolinska Institute, and they've done a very, very detailed piece of work looking at environmental factors which influence the disorder. That's not precisely to answer your question, but in essence they were unable to find any key influences that cause the disorder, and that included actually traumatic experiences in early life events. So the jury's out to the causology. The one thing I think it's really important to keep in mind when treating any of the OCD and related disorders is that ultimately the etiology doesn't govern the treatment. The treatment is very focused in the here and now. The most efficacious treatments, particularly for OCD, are CBT, including exposure response prevention. And so the modern epoch of treatment actually doesn't do a lot of referencing what the cause was. You don't know what the cause is, and it doesn't seem to influence treatment outcomes.
Time for coffee. Thank you very much all.